Welcome to another episode from the Veterinary Medicine Digest. Today, we step into the shadowed corridors of clinical diagnostics to unravel a medical mystery that sounds more like a thriller than a case report. It is a story of a silent traveler, a protozoan parasite that has spent millennia perfecting the art of survival within the very cells designed to destroy it. This is the story of canine Leishmaniasis, a disease that is well known for its devastating effects on the skin and kidneys of our loyal companions, but which, in rare and startling instances, ventures into the most protected sanctum of the body, the nervous system. Specifically, we are going to perform an exhaustive deep dive into a landmark case where this parasite likely caused a condition known as middle cranial fossa syndrome. But before we can understand this specific tragedy and the clinical triumph that followed, we must first understand the complex, shifting landscape of the disease itself. Canine Leishmaniasis is a systemic disease caused by protozoan parasites of the genus Leishmania, most notably Leishmania infantum in the Mediterranean basin and parts of the Americas. It is a disease of vectors and hosts, transmitted through the bite of an infected female phlebotomine sandfly. When the fly takes a blood meal, it introduces the premastigote stage of the parasite into the skin of the host. From that moment, a biological war of attrition begins. These premastigotes are quickly engulfed by macrophages, the sentinels of the immune system. However, rather than being digested, the parasites transform into amastigotes and begin to replicate within the macrophage, eventually causing the host cell to burst and releasing more parasites to infect neighboring cells. This silent spread continues through the lymphatic system to the spleen, bone marrow, and other internal organs. The clinical presentation of Leishmaniasis is notoriously variable, often described as a great imitator in the veterinary world. The most frequent signs reported by veterinarians include weight loss, generalized weakness, skin lesions, ocular abnormalities, and signs of renal failure, such as increased thirst and urination. However, the parasite's reach is much further. It can cause nosebleeds, lameness due to joint involvement, and severe inflammation of the muscles. For a long time, the involvement of the nervous system was considered an extreme rarity, a diagnostic footnote in the broader context of the disease. But as our diagnostic tools, such as magnetic resonance imaging and computed tomography, have become more sophisticated, we are discovering that the nervous system is not as shielded from this parasite as we once believed. To understand how a parasite usually found in the skin and spleen can end up affecting the brain, we have to look at the work of researchers who have meticulously documented these neurological incursions. In some cases, the disease manifests as a series of strokes. A study from Bellaterra, Spain, described 2 dogs with systemic leishmaniasis that suffered from presumed brain infarctions. These dogs presented with a sudden, peracute onset of neurological dysfunction. When these patients were placed inside a magnetic resonance imaging machine, the results were chilling. Multiple, well-defined lesions within the brain tissue that were consistent with ischemic strokes. The theory is that the infection causes a systemic inflammation of the blood vessels known as vasculitis. This vasculitis, triggered by the deposition of immune complexes within the vessel walls, leads to the formation of blood clots that eventually block the small arteries supplying oxygen to the brain. But strokes are only one way this parasite wreaks havoc. Other dogs have been diagnosed with meningoencephalitis, a severe inflammation of the brain and its surrounding membranes. Researchers in Italy conducted a retrospective evaluation over a 5-year period and found that out of a massive cohort of thousands of dogs, a small but significant number exhibited profound neurological signs associated with visceral leishmaniasis. These signs ranged from behavioral changes and compulsive circling to complete inability to stand. In these cases, the parasite or its genetic material was often detected directly within the cerebrospinal fluid through polymerase chain reaction testing, proving that the organism had breached the blood-brain barrier. Furthermore, the disease can manifest as granulomas, which are essentially masses of inflammatory tissue. One case report described a 7-year-old Shih Tzu that presented with an acute onset of an abnormal gait in its back legs. Magnetic resonance imaging revealed an extradural mass within the vertebral canal that was compressing the spinal cord. When surgeons removed this mass, they found it was a friable yellow tissue heavily infiltrated with macrophages packed with Leishmania amastigotes. This was not a tumor, but a physical wall of inflammation built by the body in a desperate and ultimately damaging attempt to contain the parasite. This brings us to the specific anatomical region that is the focus of our deep dive, the middle cranial fossa. The middle cranial fossa is a complex area at the base of the skull, a geographical crossroads where several vital cranial nerves must pass through a narrow opening called the orbital fissure. These nerves include the oculomotor nerve, which controls the majority of eye movements and the muscles that constrict the pupil, the trochlear nerve, and the abducent nerve, which handle the remaining extraocular muscle functions, and the ophthalmic and maxillary branches of the trigeminal nerve, which provide sensation to the face. When these nerves are damaged as they traverse this specific region, the resulting group of neurological signs is known as middle cranial fossa syndrome. Classically, if a dog or cat presents with middle cranial fossa syndrome, the primary suspect is neoplasia, or cancer. Tumors like meningiomas, lymphomas, or adenocarcinomas are the most frequent culprits, followed by infectious causes like fungal or bacterial osteomyelitis. In 2 dogs and 1 cat reported in 2009, sphenoid bone osteomyelitis, a severe infection of the bone at the base of the skull, was the suspected cause of visual impairment and nerve dysfunction. These animals often presented with sudden blindness and fixed, dilated pupils. While these cases eventually responded to long-term antibiotic therapy, an underlying cause for the bone infection was never identified, leaving a lingering question in the veterinary literature. Now we enter the core of our investigation. A case report published in early 2026 by Dr. Sergio Sanchez Briones Albafar Marin and Alejandro Lujan Feliu Pascual. They described a 16-month-old male neutered crossbreed dog, weighing only 1.5 kilograms, that was brought to their neurology service in Valencia, Spain. The dog had a 2-week history of progressive lethargy, disorientation, and most alarmingly, a complete loss of vision. The initial treatment with meloxicam had yielded no results. When the clinical team performed their initial physical examination, the gravity of the situation became clear. The dog was running a moderate fever and was visibly thin, with a low body condition score. The neurological examination was even more revealing. The patient was mildly obtunded, meaning its mental state was dulled. While its reflexes in the limbs were normal, the cranial nerve evaluation told a story of profound local damage. The dog had a bilateral absence of the menace response, meaning it did not blink when a hand was moved toward its eyes. Both pupils were wide and non-responsive to light, a condition known as bilateral mydriasis. Furthermore, the vestibulo-ocular reflexes were absent, and the dog showed signs of extreme pain when its neck and back were touched. The clinicians suspected a multifocal neuroanatomical localization. This means the damage wasn't just in one spot. It seemed to involve the middle cranial fossa, the optic chiasm where the vision nerves cross, and the cervical and thoracolumbar spinal cord. The differential diagnosis list was long and intimidating: meningoencephalitis of unknown origin, various infectious diseases like cryptococcus, or toxoplasmosis, or a fast-moving cancer like lymphoma. The laboratory tests began to point toward a systemic battle. The dog was anemic and had a low platelet count, but the most striking finding was in the proteins. The total protein level was significantly elevated at 16.3 grams per deciliter, more than double the high end of the normal range. The globulin levels, which often rise during chronic infection, were massively increased at 11 grams per deciliter. A follow-up proteinogram revealed a monoclonal gammopathy, a pattern of protein elevation that often signals a specific intense immune response. The dog was then placed under general anesthesia for advanced imaging, and this is where the mystery began to take a physical shape. A computed tomography scan of the head and neck revealed an aggressive polyostotic, osteolytic, and osteoproliferative lesion. In plain English, the bone was being eaten away and replaced by irregular new growth in multiple areas. This process was centered on the basal sphenoid and presphenoid bones at the base of the skull, precisely where the optic canal and orbital fissure are located. The lesion was so extensive that it was bulging into the cranial vault, forming a mass that was putting pressure on the brain and the vital nerves passing through that region. Because the dog had shown signs of pain in its back, the team also performed radiographs of the spine. They found additional moth-eaten lytic lesions in the dorsal processes of the first 3 lumbar vertebrae. An ultrasound of the abdomen showed an enlarged spleen and liver with an abnormal texture. This was an all-out assault on the dog's skeletal and organ systems. To find the culprit, the clinicians performed fine needle aspirates of the bone lesions in the spine, as well as the spleen and liver. The results were definitive. The cytology revealed a mixed population of inflammatory cells, but more importantly, it showed macrophages containing intracytoplasmic structures. These structures were mastigotes of Leishmania species. A serological assay confirmed the diagnosis, showing a high positive result for Leishmania antibodies. The mystery was solved. The silent traveler had established a foothold in the very base of the dog's skull. The doctors now had to decide on a course of treatment for a patient in a precarious state. They initiated a 4-week course of meglumine antimoniate, which was injected subcutaneously once a day, and allopurinol administered orally twice daily. Additionally, they gave a short course of prednisone to address the swelling and inflammation within the brain. The scrutiny of this treatment plan is important. Allopurinol works by interfering with the parasite's ability to synthesize its genetic material, while meglumine antimoniate disrupts the parasite's energy production. It is a classic, double-pronged attack. The response was nothing short of miraculous. Within 2.5 months, the dog was presented for a recheck. The physical and neurological examinations were completely normal. The dog had regained its vision, its orientation, and its quality of life. A follow-up computed tomography scan showed that the aggressive bone lesions had healed, and the mass that had been pressing against the brain had entirely resolved. This was a remarkable outcome, especially considering the destructive nature of the initial bone lesions. Now, we must scrutinize this case in the broader context of veterinary knowledge. This report is significant because it is the first to document middle cranial fossa syndrome as a presumptive consequence of Leishmaniasis in a dog. It forces us to rethink our assumptions. Before this, if a young dog presented with these signs, we might have immediately suspected a fast-growing tumor and perhaps offered a poor prognosis. But this case proves that even aggressive-looking bone destruction at the skull base can be infectious and, crucially, treatable. However, we must also address the limitations of the report. The diagnosis of middle cranial fossa involvement remains presumptive, because the authors did not take a direct biopsy of the sphenoid bone at the base of the skull. In human medicine, such biopsies are common, but in veterinary medicine, reaching the ventral area of the cranial vault is considered an exceptionally high-risk procedure. The clinicians in this case reasoned that because the sphenoid lesions and the lumbar vertebrae lesions looked identical on imaging, and because mastigotes were found in the vertebrae, it was highly probable that the skull lesions were caused by the same parasite. While this is a logical clinical assumption, it underscores the difficulty of definitively proving neurological Leishmaniasis in living patients. Another point of scrutiny involves the recovery of the bone. In another case report from 2019, a 9-year-old dog with Leishmanial osteomyelitis in its leg was treated with miltefosine and allopurinol. In that case, while the dog's lameness resolved, a follow-up computed tomography scan 8.5 months later showed that the bone defects remained unchanged in size. The bone loss was quiescent, but it had not filled back in. This contrasts sharply with our core case, where the sphenoid bone lesions healed completely. The authors hypothesized that the difference might be due to chronicity. Our 16-month-old dog had signs for only 2 weeks, whereas the older dog had been lame for 3 months before diagnosis. This suggests that early intervention is not just about stopping the parasite, but about preserving the body's ability to repair the physical damage it has caused. Furthermore, we must consider the complexity of vision loss in these cases. The dog in our core report was blind and had non-responsive pupils, which suggests lesions affecting the retinae, the optic nerves, or the optic chiasm. While the imaging showed bone lesions compromising the optic canal, a full ophthalmological examination with a look at the back of the eye was not performed. This leaves open the possibility that the blindness was partly due to chorioretinitis, which is inflammation of the eye's internal layers, another common manifestation of Leishmaniasis. This highlights the need for a truly multidisciplinary approach, combining neurology, ophthalmology, and internal medicine when dealing with this multifaceted disease. The broader implications for veterinarians and pet owners are profound. Leishmaniasis is a disease that can wait in the shadows for months or even years before showing its face. It can move into non-endemic areas as people travel with their pets or import dogs from other regions. Only about 4% of chronically infected dogs exhibit neurological signs, but that 4% represents a significant diagnostic challenge. As we have seen, the signs can mix strokes, tumors, or spinal cord compressions. As we wrap up this deep dive, the story of this 16-month-old dog serves as a potent reminder of the importance of an open clinical mind. The American scandal of Leishmaniasis is not just the disease itself, but the potential for it to be missed because it presents in such an unusual, aggressive, and deceptive way. By scrutinizing these case reports and understanding the underlying mechanisms, from the sandfly bite to the macrophage burst to the inflammatory granuloma, we become better equipped to defend our patients against this ancient and persistent foe. The middle cranial fossa syndrome is no longer just a sign of a tumor. It is now a potential signal of an infectious intruder. And while the battle against Leishmaniasis is long, involving months or years of medication and constant monitoring for relapse, the success story we explored today proves that even when the parasite strikes at the very foundation of the skull, there is hope for a full and vibrant recovery. It requires a keen eye, the right diagnostic technology, and a persistent dedication to unmasking the silent traveler. Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.